presentations out of the group. So I think Professor Shamana and I would like to welcome you formally, I guess, to the meeting. Yeah. For those who haven't met me, I'm Sue Down, Professor Sue Down from the University of Central Lancashire in the UK, and I'm the project lead for this particular project that we're there as a representative for funding this particular project, and to the WHO because they've also contributed resources to it. So we hadn't scheduled in going around and saying who everybody is, but I think we should do that. But just for the sake of time, one sentence maximum. So I'm going to hand this round, and then we've also got you on tape. And then what we're going to do is we're going to start with presentations about and from the project for about an hour, and then we'll have about an hour and a half for us all to have some conversations about the issues that arise. And if you have questions after each presentation, please just raise them. So basically today is more about us having conversations between us. Those of you who are staying tomorrow, we've got some more formal breakout groups that we want to work with, as well as doing the presentations.
On behalf of the Indian participating institution and the host university, I thank each one of you for making time on a weekday to come. I think it's a great thing that we're meeting face to face, and also making sure that we will make a little bit of more progress with respect to what we...
This is Prakashama, interested in maternal health and maternal death research studies and normal birthing. And
I am Dr. Jamuna, a private senior consultant obstetrician and gynecologist, and I did my law also at the same time, how they can practice safely.
Good afternoon, my name is Ana Pilar Beltrán from the World Health Organization, medical officer.
Sorry, I can't get up. Sexual and reproductive health issues and adolescent issues. And I'm sort of peripheral in this group. I'm always complaining to Sue about the rights perspective and the women's perspective, but I really admire this project, and congratulations.
Good afternoon. I'm an advocate, and I also head an organization called Independent Thought. We do a lot of litigation on issues of children, and in 2000 Fair Relief, which maybe I'll share tomorrow, where we generated data both of the government hospitals and the in Delhi and also the private hospitals, and it came out very starkly that in the government hospital the C-section is around 20%, and in the private hospital it was like 66%. So we made that as a basis along with the WHO standards, and we took it up that there should be certain guidelines and all. Delhi government did come with a draft guideline, which has now completed 5 years of that draft guideline. I don't think anything has happened beyond that. So it's a learning for me also to know a different perspective altogether. Thank you.
Hi, I'm Divya. I'm the Senior Manager for Branding and Communications at Fernandes Foundation. My interest is how communications can help support different stakeholders in this project.
Hi, I'm Anchita. I work with the Bill and Melinda Gates Foundation, and I lead the MNH work at the India Country Office of the foundation. So many years back, I developed an interest in rising rates of C-section and worked with UNICEF on the first workshop of its kind in India to understand the rising rates. I was the consultant who wrote the report, and midwifery came out as a huge recommendation out of that workshop. So some of those learnings still hold true of what we learn about the why of rising rates, and that I have not lost interest in this area. So happy to continue to work on this, even though this is a Seattle-funded grant, as you call it.
Hi, I'm Indy. I'm a midwife from the UK. I've been here for 5 years now. Now I'm the Director of Midwifery, and I'm training professional midwives affiliated with Fernandes WHO and UNICEF, Government of India in Telangana.
Okay, now practicing very small time in a private clinic, but then being here as part of a person who would my data analysis. Thank you.
Hi everyone, I'm Nandi Matt. I am part of National Law School of India University, and there I teach health laws, and we also run a distance learning program which is known as Postgraduate Diploma in Medical Law and Ethics, and I also run a think tank on health where we try to really look at it comes to clinical decisions. And when it comes to public health aspects, we try to look at law as a, again, a tool of development. So that's all from my end. Thank you.
I am Dr. Ambarish Bhandiwad. I am an obstetrician gynecologist. I am an academician as well as a clinician. From the academic part, I am a MD, FICOG, and then I did postgraduate diploma in medical legal system. And then I have written a book on textbooks and published about a couple of international papers and plenty of papers in the Indian National Journal. And as a teacher, as a professor, I have guided some more than 200 postgraduate students in their dissertations and all that. My clinical part, I got a vast experience of about 30 gynecology. To my knowledge, I must have done more than 15,000 cesarean sections, all types of cases.
I am A. Madhav Rao, a practicing advocate for the last 35 years. I am very much interested in associating myself with social reformative activities. Thank you.
A little comforted by my friend here. Let me see if I can tell you how I fit here. I am actually a political theorist, interested in political philosophy. And in relation to healthcare, I'm really interested more in the questions of ethics. My name is Srivatsan, and I've been associating with this group and providing some fairly odd perspectives, which I hope will be useful in handling it. Thank you.
Good afternoon, everyone. First of all, I would like I've been involved in this project for almost 1 year now, and I am a student PhD scholar under the guidance of Professor Shamanna, and we've done, I think few of you we have interviewed, and I'm very much fortunate to be part of this project, and once again welcome to the meeting.
Hi everyone, I'm Neelu. I'm a Fulbright scholar from the US at UPenn. Yeah, I'm researching with Karthik on factors influencing high C-section rates, looking at the qualitative side of things.
Just one more thing I want to bring to the notice. Myself and my postgraduate students did a study on medico-legal cases in obstetrics in and around Mysore. We started like that, and then we took all over Karnataka, and we have published a paper, and then it is printed in the journal.
Along with Sunny, I've been troubling all of you all. My name is Shamanna.
So my name is Karthik. I'm working. I'm doing PhD under Professor Shamanna. I'm also my PhD topic on cesarean section, Telangana high rates, why high rates, and I'm doing a qualitative survey. So.
Couple of more people. Grace is busy there. She's been helping us out. Grace, thank you. Aradhana is here, and Shivakumar, who deals with money, he's outside. So, and Dinesh is one of the other people. I thank my team, and I'll hand it over to Sue.
Thank you very much. So shall we move on without further ado to our first presentation, which I think should be coming up imminently.
Thank you for this opportunity to be involved and to rejudge, and I found the study very interesting. And it really gave me an insight. Dr. Shamana wanted me to talk about evidence-based obstetrics and intertwining with what is it that we need to know when we talk about rising cesarean section rates. And we all are worried about it. We are here today because the rates are rising. Worried about because we are currently seeing rates something like 80%. Okay, some of the institutions have 100%, never seen a cesarean section. But if you take a profile of India and state cesarean section rate, we vary right from 5% in Nagaland to about 60%. It's been all over in the newspapers. Many of us have been working onto it. And there have been a lot of efforts being done to find out why are we having so. And one of these studies where Dr. Shamana was involved was that, it has somehow over a period of time changed over to a kind of an elite way that is the best way. And, if you get a cesarean section run, that is the correct way. If they did not do a cesarean section, then that doctor is not good. Somehow, somewhere, we are also responsible for that trend. We had done a thesis in Fernandez Hospital on maternal request cesarean section. We take pride that, our C-section rate is very low. But then, even here, what we found was not as we thought that timed cesarean section or requested cesarean sections, okay, which on a specific day or in a specific time, but we found fear was the most important character. So I was asked to integrate, the fear of litigation, rising cesarean section rate, what other fears with evidence-based obstetrics. I'm going to attempt commonly identified reasons for rising cesarean section rate and then try to edit what is the current evidence. Now, there was a time when we would be told that getting more money for a cesarean section rate is the reason. Believe me, many of the institutions currently have same cost for cesarean section rate and vaginal delivery rates. Then why is that institute having an 80% cesarean section rate? This is very important to know, what is it? So this cannot be the reason because they give you the tariff as equal. So what do obstetricians want? We want to improve survival. We want to talk about decreasing adverse outcomes. We want to minimize cost, yes, and improve experience. But the basic aim would be to reduce the morbidity in obstetrics in whatever way we talk about. Now, most important outcome of pregnancy is a live birth. And all obstetricians don't want to have a stillbirth. So I was thinking, when I was evaluating and trying to find out why do women ask for a cesarean section, is it the fear that their baby would be damaged during the process of labor that they are calling so? Now, the answers were very varied, but let me just move forward and tell you what is the current evidence. Now, failure to perform a cesarean section led to morbidity and mortality is what we hear in almost all the litigation stories that we hear. We never hear failure to perform a vaginal birth led to morbidity or mortality is never being, it is never given as a statement at the end of it. So people have assumed that cesarean section is the best way of delivery. At some point of time along our pathway of promoting care or best care or better care, we have come to believe that cesarean section is the best way. The ideal cesarean section rate which was advocated is 10 to 15%. What is an ideal way is something that when you cross above that level, your morbidity increases from that effect, and so on. Where did this statement come from? It came from WHO statement long back. This hasn't been revised. A little later it came as, an appropriate cesarean section, but still 15%, no one has ever found that any rate more than 15% are found to be better. But we have a very different scenario today with a lot of previous cesarean sections among our midst. So, is there any evidence that if we increase the cesarean section rate to 100%, will we make the stillbirth zero? So this is an older paper at 2007, but I was searching for a relationship in developed countries and in developing countries. And over here, they have, if you take a look at the cesarean section rate, it is definitely double. But in developing countries, it is 9.6%, so much below what is the desired level. So that's why you will find antepartum stillbirth rate and intrapartum stillbirth rate are much more higher than in developed countries. But what is very important is the fraction of intrapartum stillbirths that you see over here. That is 14 in the antepartum and intrapartum 7. It's much, much more higher than what we see in the current practice or in a practice where good intrapartum care is available. Now, the second question is no one wants to have. So if it's a stillbirth, litigation occurs much less, but if it's a cerebral palsy, then the litigation is much more heavier on the obstetrician. That's the main problem that occurs. But what we know today is that majority of the cerebral palsy is antenatal in nature. But then out of those, which did not have any evidence of antenatal insult, a small proportion of them may be a labor event only. The rules or the definition for calling an intrapartum event has not changed much. So each one of us don't want a low Apgar baby. Now, for that, we put on a continuous CTG. Now, CTG has not been found to be a good tool for preventing all the stillbirths or all the low Apgar babies or all the perinatal deaths that we had. What CTG does is that it increases the cesarean section rate and instrumental delivery rate. But important outcome of it, we have to keep it in mind, is that neonatal seizures were definitely half in the group that had the continuous CTG versus those. Now, moving across from the baby to the mother, what does a cesarean section do for a mother? It increases the maternal mortality as well as morbidity in much higher way. And if you do an intrapartum cesarean section, that has the highest amount of mortality as well as morbidity. So cesarean section to vaginal birth, so severe acute maternal morbidity was double that what is seen in vaginal birth. And indeed, when we are analyzing our data set, you will never find sick cases or severe morbidity in vaginal birth, but all of them in cesarean section. So we know that cesarean section has many times morbidity. But then, important for us to understand is that there is a longer stay. There is an increased risk of PPH, infection, risk of cardiac arrest. We also have a lot of short-term, long-term events, and moving on to the next pregnancy itself, where you have an adherent placenta or a rupture uterus, or when you have adhesions, you have the risk of adjacent organ damage. So it is not that this does not happen. It happens and it continues to happen. It is not recorded very nicely because they just kept under wraps. Now, moving across from the mother to, going on to the baby, we not only have short-term effects to say that cesarean section is not the ideal way, but also a long-term effects basically on the immune development and also long-term metabolic syndromes in terms of obesity as well as other stress-related problems or autoimmune gastrointestinal problems. So then, are there any benefits of a cesarean section at all that we are talking about? The benefits has been on the pelvic floor, okay, but if you take it over a longer period of time, those wane off over a period of time. So a planned cesarean section is definitely has got effect on short-term or intermediate-term pelvic floor effects that we have. Now, if we were to move away from what an obstetrician wants, going across to what women want, women basically come to antenatal care because they want safety of their baby. They want a healthy baby, and they are also very keen that, in the process of getting this baby, they don't want any kind of an effect from the events of labor or around the time of birth. So this is very important as people are getting more aware, as people are getting, reading up a little bit more. They are very particular that they don't want any kind of ill effects from the labor to come in. So what do women want? A positive experience, healthy baby in a clinically safe environment, practical and emotional support from birth companions, competent, reassuring, kind staff. And I'm reading each one of them because each word is very, very important. This is what a woman wants, and it's very simple needs that they have. It is indeed a life transitional experience because birthing changes a woman from one state to another one, and each one of the women, there are very few women who do not regard it as a transitional experience. So it's a very important life and a phase event in a woman's life. So what are the reasons that we know today for increasing cesarean section rate? Now, I always keep on saying that, we have studied a lot, we know what the reasons are, now we need to move over as to how to prevent them. The use of cardiotocography, failure to progress, limits of normal, fear of inadequate monitoring, fear of litigation is one of them. Fear of public aggression is an important one because in India, the security is very less. So what happens is that they just, in an emotional or an anger outburst, they just come and vandalize your property or injure the person who are in front of them. Now, moving across to why do we use CTG in low-risk women? The first reason is not having one-to-one monitoring. It is indeed very difficult because you still find in the premier institutions, you will find that there is a lack of staff. We come from a country of 1 billion, but we still have lack of staff. We still have people who are not being trained adequately in an appropriate task. So poor training, failure to have systems in place. You know, my fear that if I want to do a stat or a crash cesarean section, will I have the anesthetist in place? Will I have the neonatologist in place? Will I have a rupture and will somebody be there to salvage this? So what we need is solutions right now for intrapartum support. And these are not difficult. And I'm sure each one of us is doing a huge amount of work on each one of them. But individual, every institution also needs to move down baseline and ask ourselves, what is it that I am doing to lower it down? Moving across to failure to progress, this has not been taken up very well. WHO came up with the labor care guideline, but I don't find, I mean, this is my experience, wherever I have traveled, I haven't found much use of the labor care, or it's still the standard 1 centimeter per hour that is going on, the limits of normal versus, you know, what is the evidence currently. So the evidence currently, it states that 1 centimeter per hour is not a good guideline for you. You will be ending up doing much more cesarean section than it is there. But then a mandatory use of a labor care guideline, training and hand-holding for the use of the new tool is something which is needed. Because I myself have struggled very, very much to use labor care guideline, and many times I come across so many doubts as to what do I do next, how do I react, you know, if people have used it. So a kind of a group where we can reach out to. So important points about this would be active phase of labor being 6 centimeters, prolonged latent phase is not an indication for cesarean section. And you know, when do you say good contractions? When do you actually, you know, fail your induction and say that I have really tried enough, and then define what are your second stage limits. Because many a times, currently I see 1 hour of second stage and people taking up for a cesarean section is very, very common. Not doing an instrumental delivery or not being very confident with instrumental delivery is also a reason in many institutions to have this. So the problem with instrumental delivery, again, has to do something with law, because anything that goes wrong with an instrumental delivery is an obstetrician's fault. Sometimes the fact that fetal distress was there and we have attempted might be the baseline cause rather than the instrument itself. But the way it goes is that anything that occurs bad along with an instrument is the obstetrician's fault. So something we need to change about. Now, what we have done over a period of time is that we have defined limits of normal. Where did those limits come? And then we added limits of normal for litigation. If you don't follow this, then you have the sort of litigation on you. But then at some point of time, they have become the limits of convenience also. We have changed them slowly into the limits of convenience. And you want to go run home, you want to do something at some point of time. These limits have been changing over their name to a different one. So what tools do we have which can be incorporated as no-cost interventions? One is a support in labor, allowing a person to come and be with them. This is still a challenge in many, many institutions. It's so much of a institutional practice and so much of a difficulty to get a partner into the labor ward. Even in institutions, you will find it very difficult. Now, the only way out is to work like a team. Solo practice is very difficult because then you will have so many difficulties. You cannot ultimately at some point of time, whether it's a fear, whether it's convenience, whether it's litigation, and then you move forward. Now, how to analyze whether we are doing an appropriate amount of cesareans or not is the Robson's classification. I'm not going to go through in detail, but it's a beautiful classification. Group 1 and Group 3 are the ones which have the lowest cesarean section rate. And Group 2 and Group 4 are the ones where similar patients have been converted into an induction and then the cesarean section rate changes. Our job is to keep the Group 1 and Group 3 wider, bigger, and to reduce down Group 3 and Group 4. So I would like to end by saying that evidence-based obstetrics is needed at every point. Called it normally yesterday might be very different today. And an attempt has to be made by each one of us, to think that we have to give the birthing back to the mother and move it away from hospital-centric, doctor-centric, or an institutional centric practice. Thank you so much.
Thank you so much. Thank you. Photo. Photo. We'll have a photo. Photo. Let's have a photo. We're going to ask. Yes, we'll just have this photo, and then we'll put some questions. Yeah, we'll go for questions. It'll take a while to get
Done?
the camera.
Done?
No. Okay.
Thank you.
Lovely. Okay.
Thank you.
You're very welcome. Thank you very much. So yes, we have time for a few questions now, and then we can continue.
I got some observations and some comments. Madam, your presentation was excellent. Okay. I would like to tell few things in a common man's language. There is no ideal cesarean section rate. There is no number, there is no percentage. Because before the CPA Act was enacted, Consumer Protection Act, all the obstetricians were little free. Now because that has come, they think every patient is a litigation patient. So that stress is always there. So that's why afterwards the cesarean section rate has increased. The second one is, we should look at the reduction in perinatal morbidity and mortality and maternal mortality. That's the main aim of doing cesarean section, not to reduce and then get a dead baby or a dead mother or some complicated things that happen. So as an obstetrician, you should think in that way. And then these days, there is a lot of stress in the patients. Pain threshold is less. Earlier, women used to tolerate so much of pain, but they don't want a single uterine contraction. They will start screaming. And you know, normal labor takes about 10 to 12 hours. And it is stress for the obstetrician also. Because we don't know whether the labor progresses normally or not, that ends up in a cesarean section, then he get a blame. Sir, why did you wait all these 10 hours? You could have done a cesarean section in the beginning itself. There's a retrospective, this one, that blame you get. Even the stress, obstetrician is also under stress till she delivers. That's also one point. And then these days, because the late marriages and their decision to become pregnant, they would have already crossed 30, 35 years. So there is metabolic diseases also there, like diabetes, hypertension. Those things are there, they call for obesity, as madam suggested. As per the statistics, India, there are almost 40% obese patients are there. In America, it's totally different. It's 50, both crosses 50%. Obesity, obese people cannot deliver normally. Because of the diabetes, we get big babies. So there is a disproportion between the maternal birth canal and the baby's size. So that's why cesarean, the doctors advise cesarean section. And then that's why I said in the beginning itself, there is no number or no percentage can be dictated or come to a conclusion that this is the ideal one. The ideal percentage is the one where there is no maternal mortality and then perinatal mortality because of the normal labor process. Thank you, madam.
Yeah, just one or two points. Yeah. Oh, should I? Okay. Okay. I think it was a very analytical presentation with lots of references and data from different sources. I just wanted to raise one. In your failures, why? And though in the next slide you did mention midwifery, but in the failures you didn't mention that. And I think that's the major thing, that India is a vacuum, midwifery. There's no midwifery in India. And whatever midwifery was there was, what do I say, demolished, discontinued about 40 years back. And that, I think, is one of the reasons for the rising cesarean sections. That's one thing I thought you would raise it much more strongly, because it's such a strong point. That is, you mentioned also the one-to-one. If midwifery was there, the one-to-one would be there. Because the midwifery is one-to-one. It's not one midwife to 20 mothers or so. So that's one thing I found, you didn't stress that enough, especially today with all of us struggling, and you yourself mentioned, and the midwifery guidelines of December 2018 coming in with all our struggle. The second point I thought you did say once, but I thought it would have taken a little bit more analysis and data to show how JSY, the policy change of the government of India, not just the JSY, which is a program, but over the last 20 years, the post-ICPD changes that took place, where the dye was discontinued totally. Not just discontinued, but money was not given for any dye training anywhere in the country after 97, when our RCH1 started. I think that is one major area which promoted more obstetrician and deliveries, and the NRHM and JSY, which promoted more institutional deliveries. Institutional also leads to cesarean deliveries. The third point I thought it was not stressed adequately in the failures was the mother's active participation. It is her body, it is her birth, it is her baby. And if mother is not actively participating, definitely it will be the institution or the obstetrician or the nurse taking over decisions. And that I thought was lacking. And there's so many studies, it's not like we don't have data. I'll come in later, but these are the points I have.
So I have to say, in Dr. Aziz's defense, she only had 20 minutes. I think if she had an hour, she could have covered a whole room. Yeah.
So thanks, I have a mic, thank you.
Okay, yeah, I'll give
You
you
know,
the mic.
talking about levels of C-section, just wanted to clarify that the 10 to 15% is at the population level. It cannot be directly extrapolated to any facility. So facilities, you know, higher level, which face higher, which have women with higher complication rates, would see more. Of course, that, you know, we are seeing very different things in India. So even small nursing homes, which are by no means, you know, single obstetrician-run nursing homes, which are by no means, you know, a tertiary care facility, are probably seeing a lot more C-sections than, you know, would be there. And one of the reasons, as you said, is solo practice. I think they cannot manage it. The other thing that you mentioned about, you know, intrapartum C-sections vis-a-vis the elective ones, and, you know, that we see greater mortality in intrapartum. I am just wary of, you know, by giving that message, we might be giving a message that it's an effect of C-sections. It just might be the cause for C-section, because the intrapartum C-sections would probably emerge out of a complication arising during. I think we need some sort of nuanced understanding of that, because C-section is definitely a life-saving procedure, and maybe when done intrapartum, you know, in fact, we should, when we were looking at data, we saw a lot more elective and planned C-sections rather than emergency ones. And in the northern states of UP and Bihar, where Gates Foundation is heavily funded, we actually see that emergency C-sections are missing, and, you know, the actual 24/7 availability of EMOC care, as we call it, is not there. So when a woman needs it, it's not there. And, you know, to cut a threshold, they're actually going with planned C-sections. Okay, so we've done our 6 or 10 for the month, you know, that the government is tracking in terms of EMOC provision. The third point, you know, is very interesting, and about the change in guidance, about the prolonged labor and the duration of labor. If and I'm not an obstetrician, so just as I'm a public health person, but I just, what I heard was that the latent phase of labor, according to the new guidance, it can actually go on for maybe a week also. So, you know, the point about waiting and people understanding what is the range of normality is very, very important. And from a perspective of, you know, service delivery or guiding or training people, do you think it is time we change our partographs? Because there is a heavy emphasis on use of partograph as a life-saving tool to track the progress of labor. But if our partographs are still stuck to 1 centimeter per hour and, you know, have this alert and action lines based on that, then we need to think about it. And at least in India, we're still using the 4 centimeter dilatation cutoff between the latent and active phase. And if that's changed, I think there needs to be some sort of group that shares this information, and, you know, we need to bring about a change in the national guidelines for that. So that is what I wanted to share.
Thank you. Just a demographer's perspective, you know, the National Family Health Survey 5 has come out, and there have been already some studies done on C-section changes. Of course, as you all have said, the C-sections are among better educated, wealthier, some castes, some religions. But what I found very interesting was the map of the changing profile in terms of districts and states. And there, I think, we're seeing a real change between C-sections conducted in private facilities over time. I think that's something we should be looking at. Thanks.
I must say, much of what you said was completely new territory, and I learned a great deal from what you were saying. I had one doubt. You said that natural birth and C-sections have the same, they cost the same, and yet people choose the C-section. And therefore you were arguing the cost was not the issue, right? I was wondering how you came to that conclusion. It's a very, it's not...
So current practice is, for a long time I used to think that the cost of cesarean section was much higher. But wherever, coming out of Fernandez and then going around, the costing of vaginal birth and cesarean section is the same in many institutions. And yet they have a C-section rate of 85%. Payment to the hospital.
The issue is the hospital.
Yes.
The hospitals get paid more for cesarean section, but they don't. That's the issue. It's not the cost to the patients, it's the hospital.
It's the cost to the patient is the same.
To the hospital, yeah.
The costing for the hospital may be much different because a vaginal birth does not require much. Maybe just a suture material sometime, maybe 1 injection or 2 injections, that's it. Nothing much. Okay, that's all it will require. Whereas the cesarean section requires much more with perspective to anesthesia, with perspective to sutures, with perspective to every instrument which is there. But what is the cost coming to the patient? I always thought for a long, long time that private practice, they make much more money with cesarean section versus a vaginal birth. But currently, in many institutions, you have similar cost for vaginal birth, but still they have a very high cesarean section rate. So then the second point comes is it convenience? Is it fear? Fear from both the sides, fear from the patient's perspective, fear from the obstetrician. So a lot more has to be analyzed a little later, not only the cost which I wanted to put it up. And
yeah, madam, one point here. You said the cesarean section and the vaginal on the same rate you are charging.
Yes.
We know for a cesarean, so much of expenditure is involved in terms of anesthesia drugs, and then all those things. Okay? You just say, imagine the cesarean section costs X rupees, including all those things. Vaginal costs little, because maybe 2 or 3 injections may be there. It may be costing a little less.
True, sir.
Don't you say that vaginal delivery is hyped up? If you say both are equal.
Somebody has to do a demographic survey of the costing of cesarean section versus a vaginal birth.
That's what.
It is very important that is occurring because that's the current problem which is happening. This is what it is.
Agreed.
For both of them, see, vaginal birth won't require anything. Okay, maybe 1/10, not even 1/10 of what you would require in midwife time. There's a doctor's time also. So, see, the setup is there. But as far as the cost...
And requires the nurse and the doctor to be constantly present than a C-section where it is absolutely
That's how the rates have been placed. That's how the...
What I'm coming to, Dr.
Madam,
is that maybe the cost is similar because...
I agree. Whatever you say.
I'll put it in this way. In a normal vaginal delivery, the monitoring as you are selling for 8 to 10 hours is one thing. Whereas after cesarean section also same monitoring should be done post-operatively. You can't leave the patient and go. Same, no?
So
That's what everything, both are same.
Hello, everybody. This is a very interesting debate, but it's getting very niche. So we're getting into a very small area here that we might want to unpack later. But we have got a lot of other presentations. So can I ask you to probably... Yeah, I will let you do yours. But just before I do that, so just hold your thoughts about costs for now. We'll discuss them later. But I would like to say that Anna Pilar and I have been talking about the fact that we need to do some research on this internationally. It's an area that we will not resolve in this conversation here. But it is important that we say that you have to put everything into the mix. You have to put in the length of the labour, the cost of the theatre, and the very important points. Last point,
Yeah,
last
okay,
comment on this, and then
just
we'll move
one
on.
comment.
Yeah.
Wanted to raise it, but I thought maybe this to be kept later because I found a lot of problems in your costing, and I was very sure you took it from Fernandez because there perhaps normal and cesarean is almost the same, or maybe in Apollo or KIMS or so. I'm also saying just one example I want to give because I have a little bit of history. I don't know if you've heard about Gujarat, the Chiranjeevi scheme. Some of you would have heard about this. When the rates were fixed, then they didn't have enough obstetricians in the government setup, and with the FRUs and all, they wanted to make these functional. So they said if an obstetrician would join the scheme, private or government, and do 100 births, and if for 5 to 6%, there was, I don't remember, 6 or 7% cesareans, there would be 5,000 given. For all others, there was a lump sum amount decided. And within 2 years, many private persons started having large clinics, and many government doctors went into private. So this is just to share with you.
May I counteract? It's a thought.
Okay,
that needs to be. Yes, last one.
Yeah, sorry.
Let me just finish up.
Yeah.
Recently, just about a month back, 1st of August, at Breastfeeding Week, 1st to 8th, SOMI is a Society of Midwives, did a one-day 8 a.m. to 8 p.m. study across 19 cities, just sending a postgraduate student, midwifery student, to the tertiary hospital to say every birth from 8 a.m. to 8 p.m. you observe. You observe the time of birthing and the time of putting to the breast and what sort of delivery it was, whether it was cesarean or normal, vaginal, I mean not normal, vaginal, because now cesarean is normal for many people. So they found, I'm talking about the impact on the baby. Breastfeeding is delayed in cesarean. That's a known fact. However much we may say, so that was not mentioned adequately in your presentation, I thought, besides the costing.
Basically 20 minutes, 19 minutes, okay, Dr. Shamana gave, and then, so true, I agree. I thank you for raising it up, and all of you added into what I missed out, I suppose. So a big thank you to each one of you for getting those points up. Thank you.
Thank you, and thank you, everybody. It's great to see such an enthusiastic and kind of engaged audience. So I'm looking forward to all the rest of the conversation we're going to be having. So that was brilliant. So,
I'm going to start a moment, but I stand with Luza. I gave her just 20 minutes time. Can we have the next presentation? Yeah.
So we're going to move on to maybe less conversation for the next few slides, because many of you will few sections. Because many of you will know some of this. But we want to just quickly run through the project itself. We will stop briefly after each one for any comments, but please keep all of these thoughts you've had in your heads, and we'll have plenty of time afterwards for the impassioned debate. So I think I can click this, can I? Yeah. So each of these are very short sections. Most of you will know the reason why we're doing this project, and accepting the points that have already been made, that caesarean section is a life-saving procedure when it's needed and when it's done safely, and it's critical that women have access to it when they need it, and they have access to safe, respectful caesarean under those conditions. It's also of interest that in a country like India, if you like, where the same socioeconomic conditions pertain in many parts, where women have the same kind of pelvic dimensions, if you like, as we were discussing earlier on, you still have hospitals that have higher and lower rates with similar perinatal mortalities, which suggests that even beyond the kind of socioeconomic conditions, something is going on about why caesareans are being done that's not to do with socioeconomics, women's bodies, or anything else. It's to do with the decisions we make about doing caesareans these days. This particular project has taken a number of theoretical frameworks, and one of the main ones really, or the three ones, are the theory of reason behavior, that is, or action, the idea being that people do what is easy, what's normal around them, and what gives them a benefit, generally speaking. So if the place where you work, it's easy to do a caesarean, everyone else is doing caesareans, and if you do a caesarean you get some kind of benefit, then you're going to do a caesarean. Or if you're a woman in a community where everybody else has caesareans, where choosing a caesarean is easy, and where people give you credit for having one, you're going to choose a caesarean. So the idea here is to use this theory to switch that around so that it is easy, normal, and beneficial to support women to have physiological births or instrumental vaginal births if it's safe for them to have them and if that's what they choose. We also use the WHO Behavioural Insights Programme and the Kirkpatrick criteria, which we'll come back to later. I just want to show this slide briefly. This is rates of caesarean section in India. The red is low and the green is high. So you can see a clear north-south divide. And again, the questions arise why that should be. And also here, this is Telangana, which has a section rate when this work was done at around just under 60%, but does not have the highest rate, but not the lowest rate of perinatal mortality. So even though the section rates are high, the perinatal mortality rate is not the lowest. The lowest is in Kerala, actually, with a section rate of just over 30%. Of course, if your section rate is below 10%, your maternal mortality is high. So it's true that WHO has said there is no absolute rate. That's absolutely true now. But there's clear evidence that you go above a certain rate and you don't get benefit. You might get harm at a population level. And obviously this is what's been in the press in India over the last few years, this growing notion about litigation in maternity care, which is not very prevalent, I don't think, here, although the evidence that you raised in your team is very useful in that regard, but is much higher in North America and other parts of the world, and we suspect it's becoming higher. It will increase in India over time. So this is our aim, to reorientate malpractice litigation from what we believe is a normative assumption that intervention, and particularly caesarean sections, are always going to be life-saving, to one based on human rights, evidence, and amelioration, bearing in mind that sometimes life-saving is also critical. So we are looking at knowledge about utility and outcomes of caesarean, knowledge and attitudes towards human rights, future behaviours potentially in this area. This is primarily focused at lawyers and litigation and decisions about cases, but obviously we're talking about medical care as well, potentially. Feasibility and usability of the education tool we want to develop, and then we want to create an evidence-based rejudge program that we can use to make change happen for the better for obstetricians, midwives, women and families, and obstetricians, midwives, women's families and communities and babies, obviously. So this is what we have done, scoping reviews, which Anna Pilar is going to tell you about, a toolkit which we're wanting you to help us develop today, and the rest you can see on there, I don't need to read it out. That was what we planned, and this is what we've actually done, which is more or less the same, except that we did the interviews that many of you were involved in, which were not in our original plan, because our stakeholder group, which also many of you are involved in, told us that's what we needed to do. So we did what we were told to do and did the interviews, and they were extremely useful. You will all know, some of you, you are stakeholders, and the stakeholder group has met regularly, and then the interviews and workshops, which we'll tell you more about. And this is our progress so far. So we've done the scoping reviews, which Anna Pilar will report. We've done the interviews, the workshops. We've mapped UK undergraduate law courses to find out what the content is in this area, and we'll show you those data, and we've done the before and after survey. So I shall now, I'll put the slides on. I think Anna Pilar should be next. I don't know if they're actually on here already or if they're going to be loaded. So while we're loading those slides, any questions about any of that? Is that all straightforward? Or not? No, it's fine. Talk now, we're loading the slides.
It's just more a kind of conceptual question. The choice of cesarean or natural birth, or, vaginal birth, I would have named it culture, but you named it reasoned behavior because you're following. What is the advantage of naming it reasoned behavior? Because what would it do?
People make culture. People create culture. So we can talk broadly about culture, but it's very difficult to get hold of it. But it's actually how people in a cultural setting make decisions that creates those cultural norms. So that's why we focused on people, to try to, through people, have a sense of what's going on with the culture and seek to change it. Does that make sense?
Yeah, no, the term reasoned behavior is what I would kind of...
Yeah, okay. That's just a term used by the people that developed the theory.
Okay.
So it's also been called behavioural change theory, reasoned action. There's a whole load of different names for it. I see what you mean. It's not necessarily reason, is that what you're saying? It's not necessarily logical, what people do. Yeah, that's true. It's just a term. Okay? Yeah.
Hello. Thank you. So I am going to be reporting, as Sue said, the results of the systematic review. Yes, of the scoping review. And basically, the scoping review is a methodology that we use for getting and obtaining from the literature all the information and data that is relevant to a subject, and then summarizing it in a meaningful way that we can draw conclusions. So we did this scoping review, and we summarized the finding using the WHO principles into this graph. We consolidated the different domains that influence fear of litigation. So we think, we posit that these domains actually influence doctors in the fear of litigation, which subsequently leads into the increased use of cesarean section. These three domains are social drivers, cognitive drivers, and environmental drivers. And the social and the environmental drivers influence subsequently the cognitive drivers. So we will be talking about these drivers a lot through the day, so I'm going to go very fast, but I would like to have one or two words into these, the constructs that are underneath these drivers. So let's start by the cognitive drivers. The cognitive drivers, we found 5 constructs. First one is availability bias, which is that the doctor used for judgments of likelihood, those that are based on the most recent or more emotionally stronger evidence or experience, rather than on a statistical significant evidence that comes from thousands of hundreds of cases. Ambiguity aversion, number 2. This is the tendency that we all have, including doctors, to run away from uncertainty. We actually want uncertainty. Women want promises, and we can't promise certainty. Number 3, relative risk bias and beliefs around safety. This has to do with the fact that most doctors, or many doctors now, think that cesarean section is safer, because when we use relative risk as opposed to absolute risk, the numbers are more scary. The risk is more scary when presented as relative than as absolute. Commission bias, also very well known to you probably, because as doctors we tend to have this bias into action versus omission. And the first thing they are going to ask us is why you didn't do a cesarean section. So we tend to run into this commission bias. The 5th is the loss-gain framing or loss aversion. So the pain of our losses are more powerful psychologically than the gains, that the pleasure that the gains give us. So we tend to avoid losses even if we are missing the gains. That's for cognitive drivers. For social drivers, we found 3 constructs. Patient pressure. We feel pressure by the patients and the families to conduct a cesarean section. Number 2, the social norms around cesarean section. We've discussed before, cesarean section has become the norm. And when something has culturally been absorbed as the norm, going against that is very dangerous, or at least that's how we feel that is very dangerous. And lastly, the blame culture. If something goes wrong, the blame goes on the healthcare professional. We don't want women, including me, we don't want risk, we want certainty. So these societies these days do not deal well with uncertainty and with mistakes. And not only with mistakes, you could be doing things absolutely correctly and nevertheless have a bad outcome. And we don't accept that. We want perfection. Lastly, the environmental drivers. But they have to do with the different types of environmentals that the doctors are exposed, or the healthcare professionals, sorry. The legal environment within which providers practice is very important. The the healthcare providers feel the randomness of the system, of the legal system in which they have to navigate. And they feel that instead of sticking and evaluating the evidence, the system actually goes for the emotional criteria, and the emotional criteria supersedes the actual evidence. Malpractice insurance environment, I think that's very clear. Then the third one, medical practice environment. The healthcare providers don't feel supported by their administrations, by their hospitals, by their superiors. And lastly, the media environmental. This concerns social and mass media, and we all know that social and mass media can destroy reputation and can destroy actual lives and professional lives. So just to leave you with the constructs and the framework that we put together as the influences of the fear of litigation. And just to give you a real taste instead of all the theory, I'd like to just share with you a few quotes from the review. This is a nurse: "I'm coming towards retirement. I don't want to go to court. I would put the cards on the table and put the ball in their court to make a decision. That's the only survival for our profession. Our society has spent more time on teaching the processes of suing rather than introducing the labor to the general public. Your reputation is important. No one will give you a gold medal for a VBAC rate of 95% if you make one mistake." No, none of these are Indian. Yes. And the last one, which I think is very compelling because it puts everything together very nicely. "It's almost like the perfect storm. You're going to pay me more, I get to worry less. You're not going to sue me, I'll be done in an hour." Thank you. So I'll leave you with this.
Here, a country's policy framework for handling these sort of issues. Have you not? Is that not a driver?
I think that's in the professional environment.
Other than besides the professional environment, for the professional environment to thrive in any country, you need the sort of policy decision making that is needed, right?
So do you mean at government level?
Yeah.
So the government level, like for example in India, there's agreed to reduce cesareans.
Yeah. So is that not a driver? Because unless that is in place, then you can't.
Yes. You have to. Sorry. Yes. This is not necessarily comprehensive. This is what we found in the scoping review. So there may be missing values, missing constructs here. And what is very interesting is that we didn't find any study from India in the systematic review, in the scoping review. I keep saying systematic, but it's scoping.
Just to continue with her same point, and I think you raised it also earlier, I think when we select a conceptual theory for our work, whether it's a research or a scoping review, we already delimit ourselves. And that delimitation is what you brought out, that there was no scope for putting the government policies. I mentioned the JSY. The JSY as a policy which drove women to institutions. The angle it pushed the women who would have had a normal birth, maybe 20 hours, but they would have had a normal birth, but it drove them. So this framework, when you selected for your scoping, you left out a lot of issues. I'm also thinking a little bit about, it came out in culture, I know, but a lot of this, what women feel and want, and the socio-cultural environment of cesarean sections in India, I think, has not been, I know you didn't have many studies. I was looking at India for every box, and they went, so it was basically others. But I think a lot of that has been excluded, left out, because you delimited yourself with the conceptual design which you took up. Even in the previous study, I found that the behavior change theoretical framework.
Sure. In this one, we didn't use any we didn't use. Yeah, I think this is a really important point. In this one, we didn't use any frameworks. We just looked at all the literature, but we did look at the published literature. So you're right, we did not look at the grey literature, the policy literature. Yes, yes. Yeah, really good point, really good point. So I think that might be something that we might want to pick up. Yeah.
Madam, repeatedly the fear of litigation, it is being repeated everywhere regarding this. I think in Indian circumstances, that is not the main factor. To say generally the breastfeeding is the best feeding, this, people of India especially, they believe that breastfeeding is the best feeding. So really, similarly, people are not believing here that vaginal delivery is best. So the belief system, because people are taking an easy way, it is not the question of doctors out of fear they are going for a C-section. It is not completely correct in my opinion. People are thinking that it is easier. So the risk-bearing capacity, there is change of risk-bearing capacity in the woman. And there is no patience in women as of in the previous days, olden days. So it is behavioral changes. My feeling is that.
Yeah. Are drivers from many other countries that are not India. Nothing is mutually exclusive or totally inclusive. So many of these factors will apply to a few countries, and many countries will have factors missing here. But this is the way we scientists have to start, research on something, is by seeing what the literature says and look at the gaps, the research gaps that are needed. So nothing of this is exhaustive, and nothing applies to every country.
It's not comprehensive.
No, but it's because it's like the reasons for the drivers of the increasing rates that we were discussing. Is the cost, it's everything. Because it's a very complex issue. And I like that quote that I last read, because it really combines everything together. It's like the perfect storm, because there are many, many factors, and that's why interventions are going to need to have many components, because there's no one single reason, there's no one single magic bullet that can fix everything. So this is the same thing. In some countries, there'll be different drivers, and some countries may have a single, one driver that is nowhere else because of cultural reasons.
Yes, but whatever the concepts that you have put it up, because we have to go back. One region may not have one as a priority number one, but we have to go back and look at all of them and see which is the leading one in your institution. So it would vary from institution to institution, okay, state to state, country to country, but each one of them. But what we need to look at is that which drivers are the most predominant here, or which factor is working most. All of them may be working in an institution, but which is maximum and which is the least. So I suppose this has to be taken up and then analyzed for each institution, because a cesarean section rate reduction comes down to ground level. The policies can be made up, but ultimately it has to come on the labor ward floor where you make decisions. So it has to be applied, and the proportion may be different in each institution. Thank you.
And that's why WHO recommends to conduct formative research
Absolutely.
So this formative research will give you the main or the most important prevalent reasons. Oh, thank you. Sorry. I think she was.
Okay.
Oh, no. Please. Yes.
No, this is also, when I look at the framework, I mean, not the framework, the mapping of the drivers, okay, then what I see is, did you think of doing also some cross-analysis? For example, patient pressure along with availability bias, or I know you don't have affordability there as one driver, but affordability is definitely a driver. Affordability with availability, whether you thought of that. I just want to give one example. 99, I think I was the first that I did a large-scale community-based cesarean section study, and there I took 2 districts. And now it is Andhra Telangana, but those days it was Guntur district and Mahbub Nagar. Mahbub Nagar was almost the last district in social development, and Guntur was one of the first few. So when I went and did this, just one data point, in Guntur, in one urban setting, I did both urban and rural, 22 nursing homes and 25% cesarean. And in Mahbub Nagar, entire district, hardly, even the district hospital used to have obstetrician just coming and going, and there were no private institutions at that time, 99, not many, and 4% cesarean. So there would be this cross thing of availability, affordability, social development, education. Did you think of doing this in the scoping review?
No, we didn't. We were basically mapping, that would be a next step. This was a qualitative review also. So, but I hear what you're saying. Very interesting. Yeah.
I think this presentation was very interesting. I think you've made it clear that none of these drivers are mutually exclusive. They often overlap with each other. And one may actually lead to the other, as you've rightly pointed out. So, on one of the drivers, if I understood you correctly, on the cognitive drivers, you talked about how we are interpreting evidence, and we look at evidence that speaks to a heart rather than, and in fact, interestingly, this is something that I was discussing with another colleague of mine, as I was taking the flight from Lucknow to Hyderabad last night, that's a difference that I see, and I don't mean to be, sound very defamatory, but that's a difference I've seen between how public health people interpret data vis-a-vis how clinicians interpret data. In their mind, the way the training goes, they always remember that one case that went wrong. So if they are interested in reading literature also, they would probably be looking at case studies, and they would be looking at, the intervention that works best, the drug of choice. So it's the interventions that is more of a focus. This is what you are supposed to do. Whereas this is in the whole of, care within the medical paradigm. This is one place where, the woman is not a patient. It's a physiological process that we are tracking. So the difference in thinking, unfortunately, is not built into the medical training, that how are you supposed to be hands-off rather than always intervening. And because of that thinking, and this is not just to do with obstetrics. I mean, I remember something working on tuberculosis on the national program where, the physicians were up in arms. How can public health people decide which drugs to give and for how long to give? It might be this, it might be that. And I used to say, but that, for those might be's, that's precisely why you're there. But 90% can be taken care, under this paradigm. And if something goes wrong, you're there, right? So there was that whole but they are not probably trained to think like that, because they're trained to save each and every life. So be prepared for it, and that's, and then they're on the lookout for something going wrong. So, that is why probably when we talked about that women think this is normal, this is the normal form of care, and now reality. Because if one looks at, this whole concept of high-risk pregnancy, if one tracks down each and every element, I'm sure 70 to 75% of the pregnant women would have at least one factor that would, make her a high-risk case. And then, okay, so you have gestational diabetes, C-section. Oh, you are a bit obese, C-section. Your height is bit obese, C-section.
previous C-section, another C-section. So with the previous C-section, we are creating a whole new generation of C-sections, whereas even our literature does not say that. So that risk averseness, along with, you know, the inability, I would say, to interpret the population level data and translate it to individual practice is what is making it normal. And along with this, I also would like to, you know, it's slightly different context, but like at the foundation, we are also looking at uterotonic misuse for unindicated, unnecessary inductions, especially augmentation. And other than the fact that, you know, both these have now become normal, so that, you know, how when we're thinking of from the social perspective, how we as physicians have translated this into a normal practice, and when women are coming to facilities, they're expecting that injection, you know, to be given that pain. Otherwise, we've not done anything. So that's become, you know, the standard for quality of practice. Unindicated, you are more likely to land up into a cesarean section. So there is that indirect and direct linkage, and we probably need to look at, you know, the care provision as a continuum and where all we need to intervene, rather than just saying lower C-section rates. But just
I think there was, I want to pick out, and I would be interested in, the lawyers haven't said much, but I'd also be interested in the obstetricians in this. It does seem to me this comes down to the difference between what you do with an individual and what that means at population level. And I think that is where we have a real problem squaring that circle. And I would like to have some conversation, you know, particularly with the lawyers and the obstetricians, also the public health people, but particularly lawyers and obstetricians, because I think this is where the crunch comes to an extent. But just handing over. Also, if you have any key points that you want to raise but you haven't had time to raise them, can you come and write them on the board so that we don't forget them? So I'm going to write that one on.
Sorry, I really liked your 3 components. And I thought, Prakashama, you were talking about JSY and programs. If you look at India, and you see the variation across India in terms of C-sections, this is something that's a constant across the country, JSY, other programs. So is it, I just have a question, is it that the variation that we see across the country is predominantly because of social drivers and the kind of issues that you raised among those social drivers, the norms and so on, that are responsible for the heterogeneity in C-sections in India? So just, you know, how much could we attribute to these 3 drivers? I don't know the answer, but I think something to think about.
Can I say something here? Yeah. Yeah, I've got the... See, it seems to me that it is very much a multifactorial thing where each factor is varying according to its own logic in different ways. But I would second the idea that policy and enactment and state is a major framework which actually facilitates everything else. The way in which every action is taken, the way in which the laws function, the way in which policies are driven, all of them are quite largely driven by what the state itself will support. And by support, I don't mean facilitate. It can support by withdrawing. You know, it can support by withdrawing governmental machinery from processes and thus support a privatization of the practice. So that is an extremely important thing to look at. That is the question of policy, the question of enactment. And we use the word right, but right, what guarantees the right? Is the state which guarantees the right? So we have to look at that aspect. That is the specific point, but more generally, this is a class in how to discuss an issue. It's really something. Enjoying listening to it. Thank you.
Can I just small, the last quote in your last slide, which you said it sums up everything. That's really interesting. And my only question is that, from a very uninformed perspective, I'm saying as a lawyer that this whole medical profession has been left on self-regulation because there are a lot of ethical aspect to it, and also left ungoverned in a sense because it is assumed that the person who is in charge of that situation will take in ethical way and keeping the human rights and all those aspects in mind. But if everything which is in the last quote and all the factors you did, and it only leads to fear of litigation, then that fear of litigation has taken over that whole ethical part of the things. So that's a very, I don't have answers to what I'm asking, but is it the truth now that for all these issues of time saving and money aspect and more certainty aspect and all those things, has that taken over the ethical part? If that is so, then can the fraternity left for self-regulation?
No, I think there is self-regulation in our country. It's not that we don't have self-regulation. We do have, but ethics also is part of it. Probably some percentage of women are there, or some percentage of personnel are there who doesn't follow the ethics. I can't say that, but most of them will follow the ethics, and there is self-regulation, and there are a lot of laws and enactments which most of the professionals do follow, because they have that fear of that.
Yeah. I just want to take up on Shireen and Sir, you said this about the policy, which is almost a constant throughout the country, I mean the JSY or whatever, and also the multifactorial aspect. Just with an example from population policies, and when in 2001 census or so, when demographic transition was setting in and the government found that one of the states had much reduced growth, I mean, the rate of growth in AP was reduced much faster than in other states in 2001 census, and they wanted to know what drove this. And the study indicated that the government said it's we who pushed this, because the population policies implementation in Andhra Pradesh were very strong between 97 to 2000, 95 to 2000, very, very strong with the entire machinery. So the government claimed the success as their success. It is they who drove this change in behavior of #1 status in number of tubectomies in the country. But we wanted to find out, is it just this government policy which alone resulted in this female sterilization? And then it was found that the state also had the highest, more than 90% of women's groups. They were called the Dwakra groups. The women's groups, 90%, more than 90% of the entire groups of the country were in the state. And they were working. So was it the women's initiative, or was it the government policy, and which one was more or which one was less? Do they both work together? I mean, we, with the PFI support, ANSWERS and GIDR, Gujarat Institute, we did the study for the entire state, and we found the women had a say here. That means the women themselves, for whatever reason of any of those drivers working, they decided, even mother-in-law says no, husband says no, we will still go for the female sterilization. That's in our best interest. That is what they felt at that time. And it came out very clearly. So perhaps something like that is playing, some 2 or 3 different drivers are playing in cesarean section. And that's why I raised the issue of, of cross-analysis.
Thank you. We'll move on then to the next one, which is actually for the lawyers a bit more. I think it's Joanna, is that right? Yeah, and this is a pre-record from Professor Erdmann, who's a professor of law in Canada, and she and her team did a review of obstetric litigation. So I don't know, I haven't seen the whole video, so we should all be seeing this for the first time.
I'm in Santiago, Chile, where yesterday we witnessed the rejection of a new constitution. This was a constitution that would have expressly protected sexual and reproductive rights, ensuring to everyone the conditions for a voluntary and protected childbirth and maternity. So today there is some sadness, but continued hope for the future. My name is Joanna Erdman, and I'm a professor of law at Dalhousie University in Halifax, Canada, and I contributed the legal review to the Rejudge project with the support of law students Julia Borges and Alessandra Feldstein. This review was guided by an understanding that legal actors, lawyers, and judges act with respect to the law. Their knowledge, beliefs, and attitudes shape the law, and thus also legal risk for health professionals. But the law also informs the knowledge, beliefs, and attitudes of these actors. So if you want to change the behavior of legal actors by education, or you want to make recommendations for policymakers, you must understand the law in relation to obstetric care, specifically labor and delivery. And this was exactly the objective for our review of obstetric litigation. This is also called maternity or birth injury litigation. It's an area of law that broadly includes medical malpractice claims under tort or criminal law, as well as claims of administrative breach under professional codes. These claims may be brought to and are decided by various institutions, including courts of law, but also compensation schemes and medical councils. So our specific objective for this review was to understand if and how cesarean section figures as a preventative or protective intervention within obstetric litigation. But our more general objective was to understand the nature of legal risk and reasoning within this field. That is, to understand fear of litigation in obstetric practice from the perspective of the law rather than the health professions. We had two distinct projects in the legal review, and I'll briefly describe each. The first project was a mapping exercise, namely to map all relevant English language legal research or literatures in obstetric litigation globally. Based on our mapping, we identified 4 basic types of legal research. The first 2 types are primary research or case law. These were 1, closed claim reviews, which involve an assessment of a body of legal claims, often from a single institutional source, such as an insurance scheme or a medical council. The second type of research was primary case analysis. This involves an in-depth analysis of a single case with attention to the legal issues or reasoning, often within a judgment. So, for example, one study of this kind of research, specific aspects that were identified as contentious or controversial in a UK closed claim review. Now, much of this primary case analysis focuses on the Canadian, US, and UK context. In the mapping, we also identified 2 types of secondary research. The first is medical legal research, which involves medical professionals and lawyers writing about specific contentious aspects of obstetric litigation. So, for example, this literature included writing by medical professionals who were writing on the law or legal standards and outcomes, specifically those that departed from medical knowledge or evidence-based care. And they were doing so because they were trying to inform these legal standards of care by citation to consensus statements or other professional standards. Within this literature, we also had debates among, for example, defense lawyers about legal standards, again, on causation, especially as related to birth injury. This literature, again, was very diverse. We had professional guidance for healthcare interventions and other practices, namely aspects of documentation to reduce legal risk. And last, this medical legal scholarship also addressed general themes within obstetric litigation, such as risk or interventionist culture, themes that very closely aligned with our other disciplinary scoping review. The fourth body of literature that we identified in the mapping exercise was empirical legal scholarship, and this involved empirical assessments of knowledge or attitudes towards litigation or experiences with the litigation process itself, as well as the impact of litigation on healthcare practices. For each of these types of research, I described the nature of the research, and I collected exemplary resources for each type of research. I then suggested ideas, issues, and trends within each of the body of research. And last, I suggested potential uses of this research for different components of the ReJudge project. I have to say that this field mapping was extraordinarily interesting. I shared it with the team, and indeed the field mapping proved invaluable to shaping other activities and components of the project, especially the interviews and workshops from a legal perspective. As a second project in the legal review, we conducted a thematic analysis of the closed claim reviews for publication. As a reminder, closed claim reviews are assessments of a body of legal claims related to obstetric care. These reviews differ in data sources and data extracted, but collectively they provide a rich source of material on the major clinical and legal issues involved in obstetric litigation from a diversity of legal processes and institutions. We analyzed 51 such reviews. These included obstetric-specific reviews, but also pan-specialty reviews. The reviews were undertaken from 1989 to 2020, but most of the reviews were within the last 10 years. And they were from 15 different countries across the world, with a few being multi-jurisdictional reviews. In our analysis, we compared various features across the closed claim reviews, including the many features that you see listed here, the nature of the claims, the primary clinical injuries that were involved, the kinds of clinical practices or the substandard care that were underlying the injuries, the primary legal issues in these cases, the types of evidence that were used. We also took note of any comments on the legal environment or the social context. And then what we did in this project was analyze these features against the behavioral constructs that were associated with fear of litigation as identified in the other scoping review. And the findings of this legal research were quite striking. Namely, many of the behavioral constructs that were identified in the very different disciplinary scoping review were also reflected in the legal rationality and the legal culture of obstetric litigation. So if I can put this idea plainly, we found that these behavioral constructs were reflected in the very law itself. In brief illustration, I'll give a few examples. We found that liability, for example, tends to attach to provider inaction rather than action. In other words, substandard care was often described as a failure to diagnose, a failure to manage care, a failure to intervene, a failure of clinical knowledge, a failure to follow protocol, a failure to follow up. In other words, again, we see these legal ideas reflecting a commission or intervention bias. We also found that the degree or nature of the injury, rather than evidence of a breach of standard of care, tended to determine liability. This, again, reflected motivational reasoning. That is, legal actors and liability tended to follow a motivation to compensate families, especially in the event of severe or catastrophic injury, rather than formal legal reasoning. We found that expectations of labor and delivery as a happy event created a bias or inference that adverse events must have resulted from substandard care. Again, this reflects a construct of cognitive bias among legal decision makers. We found that causation was the most contentious litigation issue, and therefore that ambiguity as to whether or not an action did or did not cause injury was especially important in obstetric litigation, and again, as especially related to severe injury, brain injury, or birth asphyxia. Last, we found that the blame was more often attributed in these cases to human error than system failure, and that obstetricians, rather than any other member of the healthcare team, were most often blamed. This set of findings relate to the construct of a blame culture. This is not the only culture present in the legal reasoning. We also found evidence of risk culture, specifically where there was an assumption in these legal cases that most obstetric risk can be prevented or managed. For example, there was a common reference more than once in the review of BirthSafe. The last thing I'll note here in the review was this overwhelming sense that good documentation above all other forms of evidence was the most important litigation asset for providers, and this included documentation around patient communication on expectations, awareness, and information. Now, as far as we know, this is the first effort to integrate behavioral constructs on fear of litigation with legal research on risk and liability in obstetric litigation. It's quite innovative research, and we very much look forward to publishing it. Thanks so much, and have a great meeting.
Am I audible? I don't think it is. Okay, thank you. So, I just wanted to sort of, I don't know, reiterate what I said last time. And if I can probably take a couple of minutes and try to be very straight and candid. Whatever I said during the last interaction did not really go well is what the sense I get. Of course, in this room we are about three hard to really, address the issue of fear of litigation, quote unquote. Madam, your presentation was so illuminating. This is a sort of convenient bargain for both the parties. So they try to take advantage of that and of a focus what we have. And I wanted to give you some kind of a primer as far as legal or litigation scenario or medical litigation scenario in India. Let me do that, because last time I was trying to apply it to C-section and that did not go well. So I don't want to make it anything specific to what we are discussing. If I am provided an opportunity, I want to give you a complete primer and try to sort of deconstruct some of the stereotyping with which lawyer friends like me and Srivastava are dabbling day to day. The first one is there is an increase of litigation. Doctors are fearing that, right? I wanted to give you a very clear understanding whether there is actual increase or it is a perception among the doctors that there is an increase. Okay, here, okay. I can stand here. Okay, thank you. The first one is, in the year 1950, even I can name it, it is Dr. Balakrishna Triambak Godbole's case, we say. So that is, please understand, when there was no Consumer Protection Act, and this case starts from the lowest court and goes up to the Supreme Court. That is the first case. That is in the year 1959. What happened in that case, etc., we need not have to really worry. But today, in comparison with that, if you calculate, what is the increase? We try to, scare, because we actually have to survive as a lawyers, right? We try to, spread that fear psychosis, and we calculate that to be 1,100%, 1,200% and things like that. In my book, I talk about that, which was circulated last time. So, the moment you hear about this 1,200% litigation, every doctor would think, oh my God, there is a tremendous increase of risk perception. So, I need to first safeguard my interest, and then to the extent possible safeguard the interest of my patient. This is one very important thing which I scenario in India. there is no the database as such. That is why we submitted these as well. But somehow we did not get any funding, so we could not been able to do that. That is what, ever since the day we established think tank at National Law School, anybody should be able to access that so that they can understand what kind of a litigation. But today there is no the database as such. And because of that, there is a lot of distortion saying that, 1100% increase. It is in comparison with one case. Naturally, it is going to be, very disturbing, is it not? No, see, that not only Supreme, sir, why I am saying when I am talking of database, there are only one during 1959, only the first one. Supreme Court in the sense, I would say, if you take Supreme Court level, it is about 1100%. That is 1,100 cases are on an average decided by the Supreme Court, where the doctor's integrity or doctor's behavior is questioned. But if you take National Consumer Commission, it is about 1,300 cases a trimester. That means you can say it is even 6,000%. You get my point? I have not taken that at all, sir. So all this distortion gives some. So there is a fear psychosis. That is why the best way we can try to bust this kind of stereotyping is building some kind of a database. Database which captures every single litigation where doctor is involved in every part of India. That sort of a census we should put and keep capturing that. But that has not happened. Right? Then where from we get 1,100? See, I actually, you asked a question. I said, sir, I only captured, my census are only in Supreme Court. So 1,100 in 1 year. So if I don't qualify it, I could have even said 6,000% litigation against the doctors. Let me spare few minutes there and tell you, sir. If you really take today, who is maintaining some kind of a data? It is insurance companies are maintaining this data because of their actuarial calculation, because every doctor is today taking insurance coverage. So they are maintaining some kind of data. If you really go there and try to see, the literature is so skewed because it is created for their purpose, madam. But when I read it, there the first statement they say, okay, you are a OBG category doctor, then your premia is going to be very high because you fall under risk category, high risk category. The second one is, the surgeons. And it goes on. And who comes at the bottom? Radiologists, and others would come under the bottom. And this particular literature and this particular, parameter is created for facilitating them. So from that point of view also, your association which you represent, I deal with them in Delhi almost on day-to-day basis. They are told systematically, look here, you are in high risk category. So you need to understand law more, you need to, keep yourself safeguarded all the time. So this is fear of litigation is not actual litigation, but the perception among the doctors that there is a litigation, right? See, this is my first point. I don't want to keep, converting it as a classroom discussion. This is, you need to somewhere keep it. I don't want to forcefully apply it to your cesarean section scenario because last time, as I said, did not go well. You try to use this information. That's one. The second one is, I am saying, there are three very important aspects which overall have transformed the doctor-patient relationship today in India. There are multiple factors, but everything can be reduced into these three. The first one is, I say, the trust deficit. When I say trust deficit, the best example I can give is, earlier, the consent forms which I used to draft, I'm talking about 17 years back when I was assisting my senior in building some kind of literature on medical law. At that time, we were consulted on consent forms. Doctor is the first party, patient is a second, doctor-patient, this is. I can show you 16 very well established hospitals in India. If you want, I can even name few of them. They clearly in their consent form uses the word doctor and client. There is no patient at all. So that consumerism has actually crept in here. So the patient also from the day understands he is a consumer of services. Madam was saying from a public health perspective, beautifully she said, see, if you are a patient, there is a morbid condition. And when you are trying to seek some kind of a remedy to morbid condition, something goes wrong, accidental slip or error of judgment, doctor cannot be held liable. That is a jurisprudential point. But it is a perfectly normal biological process. You get my point? So, the patient also, not only there, where he has gone with perfect morbid condition, where he goes with some kind of good morbidity, he considers himself to be a consumer. So he says, I am seeking services, and wherever I feel I am dissatisfied, disgruntled, I would take you to the court. This is. One more thing, trust deficit. Doctor was saying, this speaks, I have heard at least every alternate doctor talking about this. When you treat a patient, think that every patient is a political, potential litigant. This has been systematically injected into them without telling what is, the law. But they have been told, you can be dragged into litigation. 1 minute, sir, 1 minute, you can speak. See, this is where I am trying to tell you, see, that notion needs to be, changed. The second one is, I am talking of increase of what is called as profit-based institutions. You use the term institutional systems, organizations and things like that. Before we attained independence, Bohr Committee is the first committee, Britishers appointed Bohr Committee, and they gave the recommendations. At that time, one recommendation I would like to cling on to. They said 94% of healthcare facility or healthcare delivery in India happens through public system. 94%. Remaining 6% is done through, happens through private. And they said it is a very disturbing sort of a phenomenon. It should be increased because state should ultimately own the responsibility of health. Individual health should be the business of, they did not say individual has a right to health because it was a colonial government at that time. But today if you see, we did this particular calculation during pandemic. During that pandemic season, what we calculated is 74% of healthcare is today private, right? And remaining is public health. Right? That is, in the public institutional, kind of a framework. So when it is so privatized, how as a doctor, he was talking, my friend was so beautifully talking about ethics and self-regulation. So in your classroom, you are taught about ethics, you are taught about self-regulation, doing good, benevolence and all these kind of things you are taught. But the moment you go, 74% when you get into the so-called profit, motivated environment, could you able to act ethically? This is the question I am saying, asking. My obvious hypothetical answer is no. This is what my 17 years of hobnobbing with doctors tells me. Doctor can't remain ethical because he is answerable to his higher up. His higher up is answerable to the board. Board is answerable to the shareholders who have invested. So revenue generation becomes the most important aspect. Right? The last point I wanted to take is, I will try to draw an analogy if I am not taxing your time too much. Parallelly, I will just squeeze it. I will just, squeeze it and say, right now, day before yesterday, I was in another sort of a consultation where we changed organ allocation criteria in Karnataka, which created humongous amount of ruckus. Right there, we said, I don't want to really talk much about that. We could able to convince our state actors and said, as far as living donation is concerned, we require one law. As far as cadaveric supply and cadaveric donation is concerned in India, because of our socio-economic conditions, we require different set of norms, normative principles. But when law was created in the year 1994, both were mixed. That is why law has become a big hindrance here. We needed to eradicate that. So what I am trying to tell you is, if we can advocate very specifically, here, if at all there are some impediments of law, which is creating that kind of a fear, those impediments can really be weeded out. Any lawyer worth the salt can give you assurance, because ultimately law is to spread public good, is it not? So we can weed it out. And if you think, perceptional sort of a fear, which is making people to adhere for higher rate of C-section, etc., capacity enhancement among the stakeholders should eradicate it, But I have my own doubt whether that would happen. That's all. Thank you.
So it was very good to have yes, I'll come back. It was very good to have, because we had the obstetric perspective, so it's good to have a legal one. It is time to break, but I will take one more comment before we do, because I know you wanted to comment. But also, before we break, I'm going to ask if we can have 20 minutes, not half an hour, because I want to keep us having these conversations. We do have a number of more presentations. We were intending to have some more general discussion, but what I'd like you to talk about when you have your break is, do you want to continue as we are, presentation, conversation, presentation, conversation, or would you rather use the rest of the time for debate? Don't answer now. Go and have your break after we've had this comment, and come back and tell us what you want to do with the rest of your time. So,
yeah, thank you. 2-3 points I want to differ from him and tell my points. See, in our Indian culture, doctor is considered as God. Vaidyo Narayano Hari. They used to believe the doctors as a God, and his word is a final word. It was a service, actually. We used to do service to the humanity. After this Consumers Protection Act, the government, or I don't know which one, they considered medical profession as a business. We are not doing any business here. We are serving this society. It's not a business like any other business. Profit and loss. No. That second one, a patient registers a case against a doctor for negligence. To prove that he is not negligent, it will take years together. So many adjournments, because I have undergone through these things, that's why I'm telling. We have to go to the district court first, then state commission, then national commission. Okay? By the chance, so many times it has happened, doctor is proved not guilty. Then what happens? Nothing will happen. Patient will not lose any money. There is no liability on the patient. Whereas the doctor has undergone so much of stress for 4 years or 8 years. No. Shall I tell you? When they want to, if you want to complain to a commission, only thing what you need is. No, I'll tell you. I'll come to that later. I'll come to that later, man. In the beginning, if you want to complain, they need a white paper and a pen. And they say that this doctor has done so much of mistake to me, I am compensating for 10 lakhs of rupees. Okay? If the doctor is proved right, he doesn't lose. Then doctor has to go for a, I think, what's that? Another to claim that money. Okay? He can, that will take, that's a civil court. That goes about, maybe at about 10,000 rupees you will get back. If the law has made in such a way that if the doctor is proved correct, whatever the amount you have asked, you have to pay to the doctor, then all the litigations will come down. Definitely.
Thank you.
The third one.
Very quickly, very quickly.
Third
Okay.
one. Sorry. This is the important one. Recently, about a month back or 2 months back, in Rajasthan, one of the most important gynecologists, she was a merit student. She did a cesarean section. She has treated all her family members. They were all grateful to her. Here, she did a cesarean section. It was a repeat cesarean. First one she has done. This is the second section she did. You know, after cesarean section or normal delivery, patients will go for postpartum hemorrhage, atonic postpartum hemorrhage. That's one of the reasons for the maternal death. That doctor has come and told the husband that she has undergone, she is going for a PPH and we are trying our best. They did everything. Last resort, even they did hysterectomy. In spite of that, she was dead. Then they took the body home. They took the body to home, and then the local people, including the politicians, they instigated the husband, asked for litigation, asked for a compensation. So they brought back the dead body to the hospital, and they kept in front of the hospital, and they made such a galata. Then for her, for the obstetrician, the case was registered under, I think, section 302, attempt to murder. That case was there. Section 302, attempt to murder means it's a life imprisonment. How can you prove, sir, its patient has died? No, I'll tell you. No, this is lawyer's point of view, I know. He can tell this way or that way, this way or that way. See, lawyers are the best intelligent people here. Because of that, doctors are Buddhas, really, I tell you. We know only to do service.
Yeah.
But we don't know how to play with the words. Okay? Yeah. Then because of the fear of being in the jail for lifelong, she committed suicide.
Yeah. This is a real issue. I completely.
This is why I'm
it is a real issue.
This is why even though she has treated her all family members, so that's why I said that word, every patient is she may put a case against me. That's why with that eye you should see that.
Yeah, I think
with that context I told you.
I think that's an extremely important point, and I think it illustrates one of the things that we've been saying, which is that the emotional impact here is huge. So no matter what the facts of the case are, both for women and for doctors, the emotional impact is huge, and therefore the fear of litigation is real. So I think Professor Nandima's points were really important, but in order to move towards a situation where it's easy, normal, and gives me a benefit, to do what is best for the woman the whole time, we have to make sure that we address these emotional consequences that are very prevalent. I completely agree. And I think we did have a request for other people to speak, but we really must have a break. I think it'd be really good if you had these conversations during the break. I'm really sorry we haven't got all day, because I think we could have teased out some incredibly important things here today. And I would like us to try and, if we can, move towards thinking of solutions to some of these really complicated problems. But have some conversation, have some tea, have some coffee. Thank you very much for your honesty and your contributions, and come back in about 20 minutes. I think that's about 4 o'clock, is it? At 4 o'clock. What time is it now? 4:15 back. 4:15 back here, and we have 45 minutes there to decide what we're going to do. Thank you.
You are a lawyer. Imagine you are a doctor. You are in doctor's what you would have done?
Tea is in the lawn, just outside. It's in the lawn outside. Tea is.
More rejudge. Well, you're a lone voice. What we will do is we will send the slides. Those are, if you're here tomorrow, you will see we'll go through all the presentations. If you're not here tomorrow, we will send you the slides so you can see all the slides. And we will, at our next stakeholder meeting, we'll definitely, go through the detail. Sorry, Sri. Okay. So I think it's been really useful to hear what people have said and where people are coming from. I think we now need to think about how are we going to turn this around? How are we going to make it good for obstetricians, good for women, good for midwives if we get midwives, good for families, good for communities, good for lawyers going forward, with the best possible outcomes in the short and the longer term. So I think this is really more brainstorming. I think it would be ideal not to have long conversations, not to have long speeches at this point, but just short, sharp ideas of things we can do. And then if we have time, we can discuss those ideas. If we don't have time before the end of this session, 5 o'clock, we can obviously discuss them over dinner, those who are coming to dinner this evening, or those who are here tomorrow. So, and we'll probably write them up on the board, yeah. If somebody can be a scribe. So everything you say will be written on the flip chart papers without any critique. So if someone makes a comment, please don't critique the comment, just accept the comment, move to the next person, and then we can have some conversation afterwards. So, first good idea for change. I'm going to go over here, actually, because you had a suggestion earlier on.
So, just a small sharing. On the flight to Hyderabad, I saw a movie called Section 375. And at the end, the lawyers who were opposing each other in the court were also senior and junior. So they had, after the case, they were having some discussion. And the senior advises the junior who won the case. And he says that, we are in the business of law, not justice. So I think from where Professor left, I think the present situation is where the medical profession has got into real business. And they are not into that business of ethics. I think things have changed drastically over the decades. And all these stakeholders have moved from their whatever situation they were 3-4 decades back. So from a very, very uninformed gentry, the other extreme is that Google fed misinformations and all. So, but everything have moved, and the whole perception also where doctors were next to God, those perceptions have also changed. If we look at the percentage of litigation, but if we compare that with the kind of denial of healthcare by doctors or by institutions and even by private players, and also the lack of services being provided by many hospitals. So you will have mushrooming of small clinics and small shops in name of hospitals who don't have services. So they have only 2-3, section in terms of what they could provide. And once the complications goes beyond their manageable skills, then they try to transfer. So I think even the minimum standards for what can be called as a hospital, I don't know how much that is being taken care in terms of regulating the opening of hospitals or dispensaries or whatever. So solution, I think there are two things I feel can really help in the whole scenario. One is, I think we have to understand that guidelines, rules, laws helps everyone. It helps everyone from both the sides. So as on today, if there is a litigation and if there is no concrete reference point in terms of guidelines or law, it's still very subjective. The fight is very subjective. Somebody saying something, somebody saying something. And the court also with their own limited understanding about the technicality part. Why I'm saying, because our petition was dismissed through an oral judgment where the second last paragraph says the issue brought up is too technical and we don't find ourselves competent to. And then they diverted to Delhi government saying, you framed a draft, you kindly take this petition as a prayer and you continue with it. So I think any kind of framework or guideline which can be a reference point and surely and 100% be developed by people who are knowledgeable, who are technically sound. So at what kind of guideline or kind of process document can be made, whatever guideline, whatever. So that is point one. Second, I was sharing, and I said in the last time also, there is a serious need for, I think that deficit issue of trust deficit issue, there is a serious need to bring in transparency. How we bring that transparency with we treat them as client, or we treat them as patient, or we treat them or whatever, but how we engage in terms of making the whole process more transparent. Today's time, you go to any doctor, if he's a little famous one, you won't even get a couple of minutes for hearing. So he's so busy with patients. So for even a small ailment or big ailment, he will hardly give you 2 minutes, 5 minutes. And they are charging enormous amount of money compared to in the standards. So how we become more transparent, how we take that small session as a more educational exercise where you share, inform, and make them party to your decision. So how they can become more informed, party to that informed decision making, and I think that can also bring down the litigation to a larger extent. So I think two ways. One is having a rule or regulation as a reference point, basis on which litigation may or may not happen. And second is how we bring more transparency. What can be those modalities we can discuss.
It's very easy. Yeah. Just I want to add a few points. I completely in agreement with my law professor Nandi Matji. And the professor of law at Dalhousie University, she specifically stated one thing, that law shapes knowledge, belief, and attitudes. This is the most important aspect. And as everybody knows well, that the rule of law is equality before law, equal application of laws, predominance of legal spirit. That is important. So my feeling is that as a solution, lack of public policy or law is the root cause. And I am submitting my opinion with respect to India specific. Because in India, in the morning session I told, it is not fear of litigation, it's fear of media. It's a fear of physical assault. Because 130 crores population are there in India, but how many medical negligence cases are, they're very comparative, very less. So doctors now, they are under threat, they are working in India. That is practically they are doing like that. Because something happens, nobody is there to think what happened, any negligence is on the part of the doctor. Nobody will think. Simply nowadays, for the last 3 or 4 years, they are coming over to the doctor and they're beating him. And they are influencing politicians and they are putting cases against them. Avoid all these things. Why should we take unnecessary? If doctor says that this is not medically indicative, it's normal delivery is possible, then they insist for cesarean. So 3 or 4 times after insisting, doctor will think that why should I take risk? If something happens in natural delivery, I will be taken to task. So let us go. Let us agree. So my solution, my hypothesis is there must be a stringent laws. In the absence of law, nothing will happen. So the World Health Organization and all other international organizations, they should compel, I use the term compel, all the nations, because in India, there are laws regarding prenatal diagnosis and surrogacy and MTP. All are successfully being implemented. Successfully. So there is penal liability if anybody examines regarding the gender. He will be penal. So no doctor is coming forward and nobody is going to doctor for such examination. So deterrence is very unfortunate because all are not matured equally. If all the people in the world are matured enough, there is no need for law. So stringent laws must be there. Unless there are stringent laws, nothing will happen. That is my point. Thank you.
Thank you so much. I think. We have your live.
Yeah, no, I think it's working. I think what you said is absolutely right. But at the same time, what I suggest to all the single-owned doctors who are working in the districts, especially, and because if they don't do that work, and the woman cannot travel to the cities and tertiary care hospitals because it becomes very expensive. So what I suggest to all of them is that teamwork is very important, and at the same time, the locality where they are practicing, maybe in a radius of 5 kilometers or 10 kilometers, if there are about 10 nursing homes, they all should come together as, maybe they can create a WhatsApp group and form a group, and if there is any vandalism or if there is any case, immediately they can put that issue into their WhatsApp group. So whoever is, can approach or come to help, that makes a lot of difference. And I think this is needed a lot. I think that's what my suggestion would be. Yes.
Yeah, I'm going to be very specific, and you wanted some solution. Huh? Okay, first solution is, please expand your stakeholder group. I see in this room lawyers, maybe 1 or 2 obstetricians, 1 or 2 public health people, and 1 or 2 researchers. I think we need to have many more. Who's here on behalf of the women? And we need to have some either activists or women's organizations, or people who will speak on behalf of that, because we are all speaking on behalf of our own agencies. So I think that's one thing need to really expand. And second point is to have joint sessions, because you can see what passion there is. Each one of us coming from our own areas, we need to have, the lawyers need to understand also the fear and the, of the doctors and of the public also. And I think it's necessary to have these lots of joint meetings or working meetings with similar cases. There are a lot of cases which have gone to court, which have had very good judgments. So if we can pick up those, which can be useful for both groups, and that I thought would be one. But the groups must be lawyers, general doctors, public health people, obstetricians, midwives, activists, so that the conversation goes in a broader manner than in a very narrow clinical view. My third point is public system strengthening. That requires advocacy, a lot of advocacy, because we know that once there is a strong public system, public health facilities, functioning well, giving good care, and the risk of the unnecessary cesarean section at least will stop, will reduce. I will not say stop, but it will reduce. So I think that is the advocacy action point that I want to suggest, mainly to the government, so that the public health system is strengthened. Fourth point is about regulation, and I have a lot of examples that I've gone through with different hospitals. One is Sitaram Bhartiya in Delhi. I had lots of conversation with the owner of the hospital because I was looking at these cesarean sections over time. And he said that he's not a doctor, he's the owner of the hospital. He reviews every cesarean section with the obstetrician, first sitting, why did this happen? What was the reason? Explain to me, I'm a lay person, I'm not a doctor. So that even before taking up and after. And the payment is somehow linked to that. So I think there is a very strong thing here where the doctor feels very accountable for at least elective ones, and too hasty decision would be avoided. My fifth point is we have to work for system changes, not individual changes, because it is the individual who fears the litigation. It is the individual that shocking news which doctor shared with us. Such things are, very, very deeply moving. It shouldn't be happening. If we've lost a very good doctor, it's a very sad thing for the country. So we should not be focusing on individual, but look at the system which led to that, rather than that. And I have this, when I was called to the Delhi High Court to do this maternal death study long back, and very good judgments came out based on that, and a lot of reform took place. It was the entire system. It was not just one hospital, one doctor, one public health A&M to be blamed. It was the entire system that went wrong. So I think this system changes are one thing we have to learn and look at the system which failed at every case, not just this one individual failed. Finally, I feel very strongly, how we are going to do this, I don't know, but public awareness. And if we can launch very good public awareness through this forum, if we can have this as one strong outcome of this research study, what you're doing, continuously on a sustained basis. We started in 2018 the normal birth campaign. Within a month, I realized the word normal is wrong. It should be vaginal birth or natural birth or something else, because using the word normal itself was, for me, I realized what mistake we were making. So when it has to be sustained, it fizzled out after some time of nearly 10,000 people, but after that it fizzled out. So whatever public awareness campaign is taken up has to be built in such a manner that somebody takes it on and it continues, so that women and families know that the first port of call is a normal birth, then only we go for something else. These are my points for the time.
Thanks. I've just been asked, apparently people are taking pictures, which is fine, but just be sure they don't go into the social media space, or if they do, make sure you've got permission before you send them into the social media space. Thank you. Yep.
Can I? My thoughts are a bit inchoate at this moment, but maybe I'll write it down later and make it clearer. But basically, I'm thinking that in India, if, looking at it from the 70s till now, if in the 70s the system was completely paternalistic, I have seen, like I was just mentioning in a conversation earlier, that if a doctor felt that the patient was not cooperative, he would slap him. And the patient would take it.
Yeah.
Now you come to a stage where patients are litigants. Now, at some level, I think there's some improvement there. I mean, you can't deny the fact that the patient having some control over what they want is something which is important. But to take it to the exact opposite, where you become a complete client, and you treat it as a simple contract, and then you say there's a breach of contract, and you go to court against the person, then you're forgetting the fact that your life is at the hands of the doctor, and you have no knowledge about what's being done to you. So there is some way in which we must be able to go beyond this point to, I don't know what it is, some way you go beyond the paternalism and beyond this adversarial mode to, I don't know how to think about it, but this is where the incoherentness comes, but something has to be done over there. And what the problem also is described as a trust deficit, as whatever it is. And certainly, enactment and policy is absolutely important to provide the framework for the transition. Law functions like that, especially in India, it functions like that. Thank you.
We'll go here, and then Anchita, and then we'll go down that way. Yeah.
Okay.
Super.
My only solution or a request for our fellow lawyers or somebody, judiciary system, is be friendly with the doctors.
Is be what, sorry?
Be friendly with the doctors.
Doctors, yeah.
You understand at what mental stress we are working, and then please understand us. And probably, I should not put it this way, you may also need medical help. You should believe, yeah. You believe your own cardiologist, your own doctors. You cannot question them. So it is not a separate from any other person. Okay. So be sympathetic. We will be friends together. If something goes wrong, you just please advise the doctors. Sir, you have gone wrong here. Instead of putting him in court. So this is the solution I want.
Thank you, very good. So, Anchita Tripana,
So some of my suggestions match with Dr. Prakash Amma's suggestions. For example, when you talked of bringing in more stakeholders, I think even if we cannot have meetings like this, but we do need more formative research to understand the woman's perspective, what does she want? Because there is a lot of talk about women demanding C-section and normalization of C-sections as the standard of care. Is that true? Like I said, in that 2016 meeting on a very small sample, what was found that women actually feel less of a woman if she's unable to deliver normally. You know, they associate vaginal birth with being a woman. So maybe the perception that we have, because we are from the other side of the table, could be wrong, and we could encash on that. You know, that's what women want. Then, you know, from the OBGYN perspective, I would say we probably need to do a better job of especially making them understand the ill effects of unintended unindicated C-sections, to remove this perception that C-section is a safer bet. So that things can go wrong even with C-section or because of C-section, if not now, but in later pregnancies especially, and there is enough evidence on that. So there should be, we could reach out to the professional associations to spread this information more clearly. We also talked about the changing guidelines in terms of what is normality, what is the range of that, how much can you wait, and when do you need to intervene. So if that is the case, then, you know, working with the, even before maybe the government guidelines change, which might take a longer time, but the obstetrical societies can start working on, you know, their intern, and they do it for many other issues. For the lawyers, you know, I would borrow from what was shared about building a data set. Especially, I would say, you know, because I had a question on that, what is the evidence that the judges rely on to make a judgment? Is it based on social norms, or is it based on the clinical evidence, so to say? So will they go by the book, or, you know, whatever? And even if experts are called, are the experts called just to share their opinion, or do they have to present the evidence based on this, I am making this kind of. So, you know, where you get your evidence from needs to be very thoroughly decided, and it should probably come from, you know, international guidances or textbooks, something that's documented and known with data sets. And we could probably also, along with that data set, have a collation of the results of those litigation. How many actually landed up with, you know, a penalty or something for the doctors? I know the process of litigation is penalty enough. And yet, you know, just to have an understanding that in most cases we'll probably not be held guilty, might hopefully prevent cases like what happened in Rajasthan. Then also in terms of, you know, the violence and all those things, one thing is we should, even for the public sector, advocate more medical indemnity, you know, the insurance. It should probably come from the government as part of the government package. That's an advocacy. And because in most, at least corporate hospitals, they ask the doctors to have it. And in the private sector also they do. Maybe it should be part of the hospital setup, you know, everybody is covered. So that fear that I might, even if I don't go to jail, I might have to shell out a lot of money, at least that is taken care of. And most of these in medical indemnity insurance also comes with support for litigation. So in case something happens, they have a panel of lawyers. So you know that you have a place to go to, and because it's a group that's working on such cases, so probably they'll be better off it. And for violence, I don't know how much it will help, but just improve the physical security of the facilities. So just take care of, and, you know, try and put the doctors at rest. I would agree with her, you know, there is a lot of stress that they work under. So trying to build an environment that is favorable for them, for allowing them to do the best that is there. And of course, midwifery is a solution that the government has taken up, but it's going to take time, you know, to get there. So those are some of the things that I was thinking of.
Okay, thank you. Yeah.
Can I just add one point?
Very quickly, yes.
It's because FOXI has started indemnity for all the doctors, and at the same time Indian Medical Association also started the indemnity, and it is now, I think most of the doctors have taken this indemnity, and they are being supported by both the groups. And at the same time, I would like to inform that the FOXI has started the guidelines
in various medical issues, and they are available on the website for any doctor. They can just go to the website and they are authenticated.
Great, thank you very much for that information. That's lovely. Yeah.
Okay, thanks. You know, I feel that we've been talking social norms throughout and social level obstacles throughout the discussion, but discussion has gone much more towards the medical and legal aspects, which is perhaps necessary in this group. But I just wanted to say that there are also behavior change communication outlets that address social norms among women, communities, and pregnant women. And I wonder if there's a way of looking at the guidelines, curricula, modules for behavior change communication, and including in them something that changes misperceptions about cesarean section. I think that's important because I disagree with whoever said that we have great laws and everything is working. PCPNDT is not working. There are a lot of leakages. MTB Act is not working. 80% of women are getting their abortions outside of the legal framework. So unless we address women's issues and the social norms that foster these misperceptions, I don't think that we can simply rely on the other side to make change. Thanks.
Do you have any suggestions as to what we could do to make that?
I'm saying one of the things we can do is to look at the guidelines, the curricula, the modules, and see whether there are ways of, I don't think at the moment, I don't know, Prakasham may know, I don't think a cesarean section is at all addressed in modules. It's not a difficult thing to incorporate, but I think that may be a start. And then, of course, there are so many. There are family planning campaigns. There's the White Ribbon campaign. Why don't we engage with them and try to promote among communities these concepts of changing perceptions? Thanks.
Thank you. Yeah.
Thank you. I agree to each one of the, where is it? Okay, each one of the suggestions, but one of the major things that we need to do right now is to start focusing on a smaller group of primigravidas or nulliparous women who are having a cesarean section. So the data collection is currently going on for Telangana as such, but if the data collection can have only an Excel sheet or an entry point wherever it is, but not asked to calculate Robsons. They are asking people to calculate the Robsons and it's all absolutely not done well. But if the 5 parameters are put into the Excel sheet and auto-calculated, maybe those centers which are being flagged as red can have workshops being conducted so that they are aware that they are under a watch. Yeah, I think that's the first step that we should have. Group 1 and Group 2 should be on focus for just bringing about. Even a 5% reduction will make a huge amount of an impact 5 years down the line. Currently, the number of 2 previous cesarean section or 3 previous cesarean section that I'm seeing is extremely high. Is extremely high. The nulliparous group is becoming so small, you really don't know how to work on them. So on an average, the number of previous cesarean section, because it has occurred over a period of time. How do we reverse that? It is to be focused on the nulliparous group of Group 1 and Group 2, where we need to just lower it down. And that can occur only from a bigger government perspective. They are doing the data collection, but the data collection should not ask for percentages, but they should ask only for variables, auto calculation, and then, as a remedy, those institutions should either be called for or you go to that institution and have a workshop. Unless we do a data collection without a parallel kind of an effort behind, maybe we will continue to discuss, I suppose. I mean, just a suggestion. Thank you.
Yeah, that's great. And I just wanted as well to add to that, whether the units, if you do that analysis and you find some hospitals are doing quite well, it would be interesting, wouldn't it, to learn from those places what they're doing well and have those places join up, pair up, if they're not in financial competition, with other hospitals that are not doing so well, so they can share between them what their learning is. That could be quite good too, yeah. Yes. So we've got 7 minutes left, and I think we have to ask Professor Shamana. Shamana, do you say your surname, or Shamana? Sham. All right, Sham. To wrap up. But if there are any burning issues now, and you're not here tomorrow, then you're allowed 30 seconds to say them.
The government has become very aggressive now because they are on a war foot. The minister is on the war foot. And he calls all the DMHOs of the districts every day for the meeting. And he's just want that cesarean section rate has to come down. He's not bothered how, policies has to be made, how the change has to be brought. And this has put all the doctors into distress. And even the public, not only the public, but the private, both are under distress. Now, even just I was talking to one or two doctors who are working in the public sector, they were saying that now when we do a cesarean, there is a problem. The perinatal mortality is there. So we have to answerable to the attenders and the patient. So if something goes wrong, the violence is there. And if we don't do, then we have to answer the government. So every day we are under the stress, whether we have to do a normal or whether we have to do a cesarean. So that's right. So the government has become so drastic and very, I should say, I don't know, I'm not getting the words, but it has put all the obstetricians into lot of stress, at least for the past 3-4 months.
Madam, this is what happens in India actually. A person who has not done a SSLC will become an education minister. And he dictates the IAS officer. So this is what is happening. Same thing. Health system, he doesn't know any health system or whatever it may be. He is a health minister. And he dictates all the doctors to reduce cesarean section or increase the, whatever it may be. All the advices are given by the people who are not at all qualified. So something has to be done on this.
Right, so I want to end on a positive note, not a negative note. So the positive, which is, it's right that you said what you said, because I appreciate it's a real problem. We said before, if you just flip-flop from one position to another, you never solve anything. All you do is you set up conflict, resistance, and then things get worse. So it's a really good point to raise. What I would like to say is that one of the solutions is we need to talk to policymakers about taking a much more nuanced approach to this problem. And I think that's the solution out of that issue. Really short, 5 seconds. I'm going to stop you if it's not 5 seconds, and then we'll do the wrap-up. Yeah.
Well, I'm not going to say what she said, but you're counting the seconds? Okay. I think there are two types, broad and short, or immediate specific. What she said was very specific. We call in India danda, samadena danda, stick. So the government is doing the stick thing because Telangana is the highest. That will not last. That change will not last. I think we need to do a combination of broad interventions and specific interventions.
So we would say in the UK, stick and carrot. So you need the carrot as well as the stick. Yeah. All of them. Solution is those 4. Yes. You've got 5 seconds.
See, when you have the privilege of self-regulation, and if you misuse it, the state will come. Forget who is the minister, illiterate or whatever. WHO had a norm. You surpassed by multiple times. If WHO norm was 15% max, you are now having 60% and 80%. Obviously, there's a misuse. WHO were having technical people, na? They were not illiterate. Na? So when self-regulation don't work, the state has to intervene. And that's not only happening with medical fraternity, it's also happening with advertising council. It will also happen with lawyers tomorrow. if we misuse self-regulation, the state will intervene.
So again, we have to get balance between those things, don't we? Between self... Okay, I'm going to... Oh, okay. This really is the last one. I'm so bad at this.
No, I'm talking specifically about the situation in Telangana. It's true that Harish Rao, the health minister, is very, very aggressive. And he's also ill-informed. But what if there's some pressure group is able to put a set of recommendations for him? I know that he will listen. So it should be something like... No,
so we need to come up with some good regulations for him to know what to do. Cut. So, do you know, it's so much better having this than having you all sit there like this after half an hour. So it's just brilliant that there's been this conversation. And you know, again, sad we have to stop. Please carry on this afternoon and this evening if you're coming out to eat, and tomorrow. And also send us questions or whatever by email if we've not covered, or solutions if we haven't covered the ones you want to cover. So I'm going to hand over for a formal conclusion.
We're not going to let you go without a group photograph. So I've been warned that we should have a group photograph. Karthik, where do you suggest? Outside? Okay. If there are pending, travel bills, local travel receipts, etc., the administrative thing, my colleague Shiv Kumar is there behind. You can either give it to him now, or when you go back, please send it to us. If there is air travel or train travel or something like that, a TA form needs to be signed off. Otherwise, you can send us the bills, etc. Shouldn't be a problem. For those who are leaving tomorrow, we'll get the TA forms filled up in the morning. Thank you.
Maybe ask, if are people prepared to give permission to have their photograph saved? If not, don't be on the photograph. Yeah.
Yeah? Okay. Yeah. I don't know, we'll take the sort of consent of people if you're ready to be on this WhatsApp group before we create one. Yeah. Yeah.
Yeah, we can join
Okay,
them all up,
okay.
then you can leave if you don't want to.
Yeah. Yeah, just to let you know that this, the QR code which is there will have the link to the Rejudge website, and in course of time, we will be putting all the material, including the presentations and everything there, with all due permissions from people who are willing to contribute, including photographs. With permissions, yeah. Yeah, in a day or two it will be up. It's there, so I understand it's already there. These people, do it at express speed. So let's take a photograph and then probably we can disperse.
For the non-Indian people like me, we will also, the outside photo would be perfect, but one with this background would be lovely for us. So if you don't mind, double photo.
Yeah.
1 minute. 3 cheers for the photographer who's also a doctoral student.
Yes.
I have done that before. I have done it like him, so I know.